Uh, Assalamu alaikum and very good afternoon to all. Really honored to be here. I would like to express my heartfelt thanks and gratitude to all foreign delegates who come such a long way to share their experience and knowledge to treat our patients better. Um, my talk is to share with you some interesting cases, but I will share one. Nothing to disclose. Calcium is never a good friend. Expect it to give you a hard time.
Hello.
There's a take for of me. So my case, a 75 years old orthopedic surgeon male, hypertensive dyslipidemic, class 4 angina on medical treatment, create 1.5, ST changes, EF normal. So RCA 99% proximal, 80% distal, PLV 100% proximal. You can see chunk of calcium all through the RCA, and also SARC was 80% mid, 70% distal, LED 80% mid calcified lesion. So I took a fluoro, a cine. So you can see good chunk of calcium can be seen in both proximal LED and SARC, and also in RCA. So significant lesion in proximal parts, but not quite sure about the osteal involvements. And angiographically, it is a TVD with significant calcification in all three vessels, extra bonus subclavian lobe. So, as it is supposed to be an interactive session, I would like to ask my fellows and juniors, question 1. 75 years old male, hypertensive dyslipidemic, TVD, class 4 angina, ECG dynamic change, EF 60%. A simple question to start. A, cabbage. B, multivessel PCI. C, optimize medical treatment. So, according to Synthesis score, it was 34 to 12.8% mortality in PCI, but 9.7% cabbage. Euroscore 0.76. So we definitely offered the patient cabbage, but the patient refused. So question 2, what imaging modality do we need to decide whether we need plaque modification by rotablation or not? A, coronary angiogram. B, IVUS. C, OCT. D, any of B or C. So what Professor Azam take to see the lesion, prep the lesion, we need an imaging modality, either IVUS or OCT, any of B or C. So IVUS was planned to determine morphology and decide the amount of calcium, to assess osteal involvement, and to assess post-stent optimization of the stents for long-term outcome, MSA. So we did LED SARC first, then RCA after 1 month, because create was high, 1.5. So XB guiding taken, IVUS done, and this was his IVUS. IVUS showed a significant calcification in proximal lat with superficial calcium of over 270 degree, more than 5 millimeter. And to my utter surprise, which didn't see me angiogram, LED was also significantly stenosed. It was 3.9. So question 3. What are the IVUS criteria for rotablation? A, calcium arc more than 270 degree for a length of 5 millimeter. B, calcium arc of 360 degree. C, calcific nodule. D, adjacent vessel diameter less than 3.5 millimeter. E, any of the two of above. So what Professor Azam showed, any of two of above should be taken as upfront rotablation. No cutting balloon, no scoring balloon. So as the patient has got already 270 degree more calcium with more than 5 millimeter, so we take 1.5 bar with 180,000 RPM to ablate the calcium, and final polishing run done smoothly. And this was post-rota IVUS. We need to confirm what you did, is it effective or not, which is shown my previous speaker, that prep the lesion. Once you put the stent, it will not expand if the lesion is not prepped properly. So we need at least 2 cracks in our calcium in the opposite side, preferably, to expand the stent fully for having a good long-term outcome. So then stented, this is the final shot. And then we plan for the RCA for a stage procedure after 1 month. Before that, we check the left stents is doing quite well. And you can see the calcium in the RCA. And luckily, the PLV has opened up, but still there's 3 or 4 significant lesions with calcium. So a BMW were taken, IVUS was tried. While I was pushing the IVUS, catheter is backing out. So it is not passing through the lesion. If IVUS does not pass, the threshold of rotablation will be low. So again, microcatheter was not crossing the distal lesion. I took rotawire and started with 1.25 bar. But it was stuck in the lesion, it's not crossing. So I need to speed up my rota bar RPM to 220,000 to cut through the lesion. Because if I speed up the bar, the cutting power of the rota will be increased. And then it went, but not very smoothly, struggling. And then at last I reduced the RPM in 160,000 to shape the lesion properly and to get a bigger lumen. If you lower the RPM, the lumen will be a bit more. And in our part of world, we need to use 1 rota because cost is an issue in our parts of world. So went to the distal part of the RCA and then the PLV and dilated. And this is the IVUS post rota. And again, I confirm, is there any cracks? You can see 2 cracks on the opposite side of the 360-degree ring of rota. Now I can expand my stent. And another signs of effective plaque modification or rotablation is reverberation. If the plaque is shaved off, if it's thin, then you will get some reverberation, which I'm showing on the right side. And then I put a 2.75 48 synergy stent, dilated, then took another 348 stent to deploy proximally, but could not cross the distal stent to overlap after several attempts. Question 4. If I can't cross the distal stent with the proximal stent, what to do next? Dilate the proximal part of stent with non-compliant balloon, body wear, anchor balloon technique, supporting catheter like Godzilla, or E, all of above. We can try all of these things. So I took the stent over the body wear, again failed. Then dilated proximal side of the distal stent, failed. Then I took Godzilla over a balloon to give support to my stent to take it, overlap the distal stent. And you should always mark the proximal part of Godzilla because sometimes stent stuck there. So I intentionally keep a senior there. Now I cross the stent, stented. This is the MLA of the distal RCA. This is the stent MLA of the overlap area. This is proximal RCA. And this is the final shot. So take home message, imaging technique helps decision making in complex cases and saves both time and hardware. Proper planning and tools should be used to deal with calcified lesion, and bed preparation should be done optimally before placing a stent. Importance of post-stent MLA by IVUS is placed as it determines the long-term outcome. So my take for the juniors is, before putting any stent in a calcified lesion, first prep it, be sure that there are cracks, balloon expanding, then put the stent. Because if you don't prepare the lesion and put the stent, you'll be stuck. And secondly, remember, if you do IVUS, post-stent MLA is the most important thing to see. It is more than 90% of the, or 80% of the distal reference vessel diameter, because it will predict long-term outcome. Thank you for patience hearing.